Hello, everyone. Good morning, good afternoon, and good evening. We'd like to invite you and welcome you to this webinar on capturing the landscape of health service delivery and public-private partnerships in fragile and conflict-affected settings, organized by the FCAS TWG, Health Systems Global, and hosted as part of the Private Sector and Health Thematic Working Group as part of our ongoing mutual learning series on redesigning mixed health systems during COVID-19 and beyond. So welcome, everyone. We are delighted to continue our collaboration with the FCAS TWG since our last webinar on September 19th on delivering UHC in frontier economies, where we explored the role of local businesses in strengthening health systems. My name is Priya Balasubramaniam. I'm affiliated with the Public Health Foundation of India and direct Center for Sustainable Health Innovation in Singapore. Welcome again. So before we start, some really quick housekeeping rules. So today's webinar is in the format of a 90-minute roundtable panel discussion with a couple of slides. The webinar is being recorded and will be available via our website, www.innovationforuhc.com, and social media, and we'll email the recorded link to audience members as well. We would like to invite you, our audience, to ask questions during the webinar through the Zoom Q&A function, which is now open and available to you on your control panels. As well as being able to type your own questions, you can also upvote questions that other audience members are proposing using the thumbs up button on your Q&A panel. We will open the floor to questions at the end of the second part of the webinar before the last presentation. So towards the end of the webinar, we will also draw on some of these questions and address this to the panel at large. So I will now begin with a short introduction on what mutual learning series are all about, and then hand over to my colleague, Barbara. So we are a group of health systems researchers, the private sector and health thematic working group from various institutions in the global north and south. And we've really been focusing on better understanding the role and diversity of the private sector and mixed health systems. We're especially interested in how and what kind of evidence is needed to better engage the private sector and government in partnering on interventions for strengthening health systems, universal health coverage. So the mutual learning series workshops were really a short series of digital roundtables that explored how government and the private sector are collaborating in response to the COVID-19 crisis, and what kind of lessons we could learn from this collaboration that could give us some insight into the mechanisms of engagement that could be applied to redesigning and building on health systems capacity for UHC. So we had our first meeting on new partnerships model on the 24th of June. Our second meeting on the 29th of July focused on governance and regulation of private sector and mixed health systems. Our third meeting on the 14th of September was a parliamentary dialogue held with the Global Parliamentary Alliance on shaping new partnerships and the role of parliamentarians in addressing accountability and regulation. And our last meeting was really around the role of evidence in engaging public and private sector stakeholders. So what really began as a digital unconference in the beginning of June has actually resulted in an outcome for a mutual learning platform. So the objective of this platform and the series was to actually generate fresh ideas on how private sector delivery and access can engage researchers to partner more effectively with one another, as well as with governments and public health mechanisms across populations and levels of care. The mutual learning platform that has kind of evolved as a result of this series is to really interrogate evidence and engagement around mixed health systems more deeply. It's a collaborative platform for shared value creation and alignment between both non-state actors and governments to identify health priorities for intervention and engagement to strengthen country health systems. We envisage this platform to be a convening platform where we can bring together a range of stakeholders, such as those in this meeting, to matchmake for partnerships for change, enable research networks to work with private and public sectors to pursue new research directions in mixed health systems, and enable and support intervention-based partnerships at national and regional levels. So welcome again on this first hosted series on our mutual learning platform. And I'd like to hand over the session to my colleague, Barbara, who is part of the FCAS PWG. Over to you, Barbara, and you can take it from here.
Yes, thank you very much, Priya, and thank you also to the Mutual Learning Platform, the Private Sector in Health Thematic Working Group, for this collaboration and for hosting today's event, which will be dedicated to capturing the landscape of health service delivery and public-private partnerships in fragile and conflict-affected settings. So good morning again, good afternoon, good evening to all participants, and welcome to this webinar. My name, as it has been said, is Barbara Profeta. I work for the Swiss Development and Cooperation Agency, and at the same time, I am a member of the steering committee of the Technical Working Group on Fragile and Conflict-Affected Settings. And within it, I'm responsible of a thematic subgroup that looks at engaging private sector in health in FCAS. So today's event has been co-organized by Anne Canavan, who is here with us today, who will briefly introduce herself. Anne, over to you.
Hi, everybody. Just to say hello, welcome to the webinar, and very much look forward to hearing all the speakers present on some of the formative practices in fragile conflict-affected states, and hopefully having the chance to have a wider discussion with all of you here as participants, and capturing some of the very formative experiences that we can continue to build on even beyond this webinar. So look forward to it. Thank you all.
Thank you very much. So Anne is a member of our advisory group to the Technical Working Group on Fragile and Conflict-Affected Settings. My role today is to facilitate this event, and I will start by briefly introducing to you our 7 speakers for today. We have, in order of appearance, if I may say so, Nigel Pearson, who is a medical doctor with 20 years experience in developing and evaluating health strategies and humanitarian responses in complex emergencies and disaster settings. His special focus areas are health systems in challenging environments, refugees and displacements, child and reproductive health, including nutrition, infectious and chronic disease. And Nigel has recently written a report for WHO EMRO, which is going to speak about in his presentation. Michael Chomey has 25 years of experience in designing, implementing and monitoring and evaluating global health and community development programs with a diverse network of partners, including USAID, DFID, the Dutch Ministry of Foreign Affairs, European Commission, Global Fund, KfW, Bill and Melinda Gates Foundation, development banks, social investors, and UN agencies. He has over a decade of experience working in fragile and conflict-affected settings. We have with us also Dr. Momo Nguyen, who is the National Director of the Sun Community Health Department at PSI. She has been working at PSI for more than 15 years and has been primarily responsible to manage health service delivery through channels such as privately owned general practitioners, rural-based volunteers, formal and informal private sector pharmacies. We also welcome with us Dr. Harry Jean, who has 40 years of experience in fragile settings in Africa, the Middle East, and Asia. He has worked with NGOs, faith-based organizations, the UN system, the private sector, academia, and in supporting governments as well as opposition groups, and also with donors. We also welcome Buthaina Atal, who is a medical doctor with over 10-year public health experience in teaching, conducting research and program management in Yemen and a number of Arab countries. She's currently an associate professor of public health at Sana Medical School. We also introduce to you Professor Abdi Dalmar, who is the founder and executive president of the first Somalia-focused research leadership and development institute, with an extensive experience in handling all aspects of humanitarian and disaster assistance research and programming, as an implementer, a donor, and academic. Dr. Delmo is also the president of Benadir University and the head of the Somali Research and Education Network. And last but not least, we have David Clark, who currently works at WHO in Geneva as a lead technical specialist on health law and governance. In his capacity, he leads on private sector engagement for UHC, anti-corruption accountability and transparency in health, UHC law, and working with parliamentarians to achieve UHC. David is particularly involved in mobilizing the private sector for the COVID-19 response. So welcome to all our speakers. Just briefly, as an introduction, why does it matter to talk about FCAS, or fragile and conflict-affected settings, in the pursuit of increased understanding of private sector engagement in health? Otherwise, why is it that we are proposing this seminar of today? Well, the COVID-19 pandemic has exposed the fragility of health systems around the world, even in places that are usually not associated with fragility. At the same time, previous webinars in this series have highlighted the fact that new forms of private sector engagement and public-private partnerships were born during the COVID-19 response as pragmatic solution under the pressure of the needs and the urgency to respond to new threats. So finding a pragmatic and innovative solutions to unexpected shocks, rapidly adapting to uncertainties, and navigating permanent flexible thinking are actually attitudes that are very familiar to fragile and conflict-affected settings. The current global situation, therefore, represents, in our eyes, an opportunity for looking at fragile and conflict-affected settings with a new lens, one that moves its focus away from chronic failure and contributes instead to broader discussion about UHC and the mixity of health systems. So the goal of today's webinar is to explore promising working practices as well as empirical knowledge that has been mainly acquired through trial and error approaches in fragile and conflict-affected settings contexts, with two main objectives in mind. The first objective is to look at how better documentation and learning from this context experiences can be achieved to the benefit of the broader UHC agenda. So instead of being forgotten, fragile and conflict-affected settings should be systematically included into mainstream discussions on UHC. And the second goal for today would be to use this opportunity to expand the community of practice around private sector engagement in fragile and conflict settings. So all of you who are listening in today should feel welcome to contact this community and engage with one another beyond this webinar. Before moving on to the presentation, a brief outline of the agenda that all of you have received or read through before registering. We will start with Dr. Nigel Pearson, who will set the scene to better understand the role of private sectors in fragile and conflict-affected settings, and some hints on minimum requirements for trying to achieve effective engagement of the private sector in this context. He will be followed by four presentations that will highlight concrete experiences from various contexts of private sector engagement that contribute to improve people's health without financial hardship, and or that are ensuring the continuity of healthcare services amidst dire circumstances. That would be Michael Chomi and Dr. Momo Lwin on Myanmar. That will be Dr. Harry Jin on Afghanistan, Dr. Butaina Atal on Yemen, and Professor Dalmar on Somalia. We will then open a short Q&A session for you to interact with the speakers, and we will let David Clark close with linking the practice with global policy work that is conducted by WHO on private health sector engagement. So without further delay, I will now give the floor to Dr. Nigel Pearson for his presentation. Over to you, Nigel.
Thanks very much, Barbara. Barbara, can you confirm that you can see my slides now?
Yes, I do confirm. Your
Perfect,
slides
yeah.
are visible.
So good evening to you all. This was a wonderful piece of work that I was asked to do to try and summarize how the private sector is engaging in providing, involved in UHC in Middle East and North African countries. This was done for the EMRO office in Cairo, and thanks hugely to Ali Ardalan and Hassan Salah, who were so instrumental in getting this together. My starting point was really to summarize 9 in-depth studies that were done in countries in the region that were considered to have a protracted crisis. Just to say, I've done quite a few slides, so I'm not going to go through them all in detail, but they will be there for people to look at later on. Generally across the region, investment in health is insufficient to provide UHC. We're looking at UHC levels of about 50%. Public spending tends to be low. Use of the private sector is high, but we often don't understand exactly the role that the private sector is paying. In general, the population is not well covered with prepayment mechanisms. There's not very good public health insurance. And where there is, it's not always that efficiently used. And of course, there's very high out-of-pocket payments by people. The countries in protracted emergencies tend to be down this end of the spectrum in terms of public spending on health. Apart from Sudan's an exception here. And also, unfortunately, we don't have data in this particular slide for Libya and for Syria, which actually had very generous public health systems and still do. Were performing relatively well before the crisis, but of course they've been exacerbated by years of conflict. I won't go into the detail of every country. I think the main thing to say is that, of course, every country is totally different. It's a very unique scenario, a unique combination of factors. Often the conflict, it may be across the whole country or it may be very localized. So it's difficult to make sweeping statements. And this is why the studies were so important, to illustrate the complexity within each one. So we had some that had very strong public health systems like Libya, Syria, Iraq, Yemen before the war. But of course, this has been eroded over time. Whereas a country like Somalia, which is still really piecing together some of the cores of its public health system, and then working out how to engage the private system, it's really sort of, it's asking some of those essential first questions. We were using for this study a market system approach. And again, I won't have time to explain this in a huge amount of detail, but at the essence, you have in a market, you have this core of supply and demand. So we have the demand for a service and the supply is met by the private sector trying to provide it, whether you're going to a shop and you're buying something, whatever. Around it, you need a series of rules that set the ground rules for how people engage, and that includes the regulations, laws, etc. And then a series of supporting functions, which infrastructure, information, skills, and related services. We tried to create this for looking at the private sector and health systems. And we were saying that if the demand that we have is to have the need for universal health coverage, and to supply that, we want to see how the private sector can be involved in providing that. So we used some of the, EMRO has a very good framework for studying the private sector, and we sort of tried to mirror this onto this. So on the governance, the rules side, which we've called governance, we have policy and legislation, regulation, and then contracting, purchasing, modeling. Then the core functions we've sort of divided up into the key resources that are needed to make things work. So we need material resources like buildings and supplies. We need information resources, finance, and then that form up the core functions. But we also have to have critically the support functions, which relates from a private sector perspective to having a very good business and investment environment. Otherwise, the private sector does not know how to get involved. Brief scale analysis, the private sector, it plays a very large role, but what has happened in these countries in protracted emergencies is the private sector is expanding quite rapidly, but as it expands, it weakens. Because the business environment is often so confused and so dysfunctional, And it's actually very challenging to run a business in a country like Yemen, for example. Instability is holding back business at the moment. So despite the fact it's expanding, the quality of what it can provide is questionable. Private health expenditure is very high in these countries, but we don't really understand where that money is going to. We don't understand the quality of what the private sector is providing. Private facilities tend to be concentrated in urban areas. They tend to not provide preventive services. They tend to provide quite a narrow package of health services. It's often said that there's many more private hospitals, and there are in some countries, but actually they tend to have a lower percentage of hospital beds. So you have a big hospital, but it doesn't necessarily mean it has a huge number of beds. We've broken up some of the findings along these lines of the market systems approach. So under policy and legislation, we've mentioned this exponential growth, but it's really unrelated to the strategic health needs of some of these countries. So it's not the government that's setting the agenda, it's just that the private sector is swelling and filling a potential gap, but we don't know how effectively it's providing those services. There's a gap between policy. Often countries, they have policy, they have legislation, but there's no implementation, there's no follow-up, there's no application of those policies. On the regulatory side, the ministries cannot keep up. The ones that do license and regulate really can't keep up with the private sector, apart from one notable exception in Sudan. The capacity of most ministries to really get out there and have this oversight role is still quite limited, and it's difficult for them to expand quickly enough. A few exceptions we're seeing is when the regulatory role is being decentralized out to local government. So for example, in Pakistan, the setting up of healthcare commissions is perhaps bringing in some change, but it's a bit early for us to be able to evaluate the effect of that at the moment. On the contracting and purchasing side, the public-private partnerships that get lots of focus, but even in the stable high-income MENA countries lack the capacity to manage PPEs very well. And of course, this is exacerbated when you come to a country that's in conflict. And so the complexities of trying to make PPPs work in these kind of settings, I think, poses whether that's really the focus of a country that is in a protracted emergency. We have a lot of contracting out models, particularly of EPHS, Essential Package of Health Services. Usually this is to NGOs, not necessarily the private for-profit sector, which was the sector I was looking at in particular. But we have some quite good examples of contracts that work, but not necessarily to the private for-profit sector. On the health financing scheme, health insurance schemes, as I mentioned, they're not usually bringing in the private for-profit sector very much. The private health insurance market is very limited. Government health expenditure, of course, is often very inefficient. And so even in a country like Libya that spends hugely and buys lots from the private sector in terms of equipment and supplies, the efficiency of how that is used is highly questionable. And so therefore you will not get the essential things you need in the health facilities. Information resources, the quality of data is extremely limited. And until we have quality data, I think it's very hard to engage the private sector unless we understand them. And we'll look at some tips for how to do that. Look at supply chains. Some countries, lots of the drugs are produced in the country, like in Syria. Pakistan has lots of pharmaceutical companies. The problem is do they meet good manufacturing practices? Are they actually producing the good quality drugs that are needed? And how do the supply chains work around them? And just that final point about the business environment. There are some examples of successful incentivization and giving of loans to private companies, but in a protracted crisis, the risk, the corruption risk, the exposure to clientelism is very high. And so that's quite a risky strategy. You need to have very strong public financial management systems in place to be able to manage that properly. I think what I'll do, instead of going through these next two slides in detail, what I'd like to do is come to this, so we spend a bit more time looking at the looking at how the model can be used to work out some of the solutions that we need. So if we look at the governance of the private sector, the where the arrows represent sort of, in a way, quick wins, whereas it's very hard for a government that doesn't have a regulatory system in place to rapidly introduce one, although that's the ideal and that's the long-term vision. It might be better to have a focus on quality assurance. And that quality assurance may be government enforced, or it may be via getting the private sector to do their own voluntary assurance schemes. Or they can join schemes like EMRO's patient-friendly hospital initiative, which is being used in Pakistan and Yemen, for example. Or they can get ISO certification, or there's various international mechanisms that they can join. So I think if ministries can work with the private sector to say, look, you guys come up with some of the solutions, particularly on the quality. If they can prove quality, then that would be hugely important. Similarly, on the information side here, the data, it's very hard for the public sector to bring in the private sector if it has no data on it. We need data on numbers, we need data on health information, we need data on the health expenditure so that we can actually link the financial inputs into the health outcomes. And again, is there a way of trying to get the private sector to contract certain private sector actors in to help work on health information systems for the private sector, to get them to track their data better, to track their finance better? So there may be wins around that, but without information, we can't do any of this. It's very hard to know the impact, and we certainly can't attribute anything to contributing towards UHC unless we have data. So that's really critical. On the policy side, ministries need a lot of resources, and they need really good people. They need to bring in very good people into ministries on the policy side, and that needs to be applied. They need to be really working with the private sector to work out what is the best legislative environment in which they can work. On the contracting side, I've already mentioned some reservations about setting up complex PPP mechanisms, but some countries have had relative success with decentralizing some of the contracting to lower levels. That clearly works well in states with provincial structures, but again, it might be possible even in smaller states. If there's more local engagement with private sector, there's much more possibility to have eyes on what's going on and to have supervision. In terms of the supporting functions, very important to get the private sector to set up its own associations. This is very weak across the region. They're not, the private sector actors are not even talking to each other, the hospitals or the manufacturers. So to get them to syndicalize a little bit, set up associational structures, and on the medical side, they can certainly, if they have that in place, they can do more of their own quality assurance as well and standard setting. On the technical side, I think there's huge scope for the private to use this explosion in the private sector, IT sector, to use them, bring them in to manage data platforms and provide other, and also management tools, with the possibility of, can you not contract out the management even of a public hospital to a private actor? That can be a really good model as long as there's this transparency in the contracting process.
2 minutes, check.
Yeah, I'm just wrapping up, Barbara, thank you. Human resources, from the studies, we didn't have a huge amount of detail, so we don't really understand very much on the private sector, the human resources. So we need to understand it much better to work out how we can capitalize on it and use it better, and also use the sort of private sector workforce in the public, and also how the public sector workforce relates to the private sector. So not a huge amount to say on that. On the manufacturing side of pharmaceuticals and things, huge potential, but you need good manufacturing practices in place. You need a capacity of the government to supervise it. And a sort of final point of this is not just the role of the health ministry. Anything with engaging with the private sector is a whole of government approach is needed. You need very strong trade and industry, Ministry of Finance, so that the judicial side, so that the rules, the setting of how private sector actors can be engaged is totally transparent. You have ease of doing business, and then you have the quality standards and the checks as well. So, and that implies a certain level of capacity within the government. So this may be, there's some functions that perhaps cannot be performed when a state is going through a protracted civil war, for example, but that can be picked up in the phases following that. So just a few thoughts. There's a bit more detail in the slides, and happy to answer questions later. Thank you very much, Barbara.
Thank you very much, Nigel, for this extremely comprehensive presentation about your EMERA study, which actually is going to be published soon. So the participants to this webinar had the chance to hear to some of the results before reading the full report. We open now the second part of the webinar. Sorry, I am not on video. We open now the second part of the webinar to hear about concrete experiences and promising models for engaging with the private sector in fragile and conflict-affected settings. I would like to start giving the floor to Michael Chommy and Dr. Momo Luin to tell us about PSI practice. Over to you, Michael.
Thank you, Barbara. Hi, everybody. Greetings from Yangon, Myanmar. Thank yous to Barbara and the FCAS Technical Working Group and, of course, Health Systems Global for allowing me to talk about PSI's social enterprise work, particularly in fragile and conflict-affected settings. I helped expand social marketing programs for PSI in Afghanistan and South Sudan, here in Burma now, and I truly believe in the power of working in concert with established private sector mechanisms in these settings. So it's nice to be here. Okay. So PSI is currently in the process of identifying countries throughout the world with strong social marketing programs that can be taken to scale and ultimately be financially self-reliant, given the sporadic donor support these days. Several fragile states, including Zimbabwe and Myanmar, have been identified. And some of you may know about our sister NGO, Green Star Pakistan, which has already become a well-established independent network member. So throughout the world, PSI aims to serve a particular person, and it's generally a woman, and she generally occupies, we like to say, the middle of the pyramid, if you will. Often the missing or forgotten middle. We've given her kind of a composite client name, and we refer to her as Sarah globally, but she goes by many, many other names in our country platforms. Here in Myanmar, we call her Susu. So Susu may be trying to maintain her household in the middle of a civil war or an economic meltdown, but she still wants to be treated with dignity, respect, and be valued. This is just a something, it's an internal, part of an internal document, but I kind of wanted to share it with you all because most of you are practitioners, and I served as country director for PSI Zimbabwe at the height of their economic meltdown. And oftentimes our Protector Plus condoms were the only product on the grocery store shelves during those horrible times. And economic instability has yet to go away in Zimbabwe. And this kind of SWOT analysis is just from a couple of months ago. And it's part of a situation scan summary for a new oral contraceptive. And you can see in the lower left, political and economic instability is just a perpetual threat. It's essentially a consistent variable that needs to be accommodated in all stages of the planning process. Okay, so PSI has been deeply engaged with social marketing and private sector work around the world, and for 50 years. We're celebrating our 50th anniversary this year. You can see we've demonstrated revenue generation prowess over the years. We have access to a range of sexual reproductive health products, and we get good volume prices in the market. We've established numerous partnerships with the pharmaceutical and manufacturing world and have been deepening our digital health experience over the past decade. And over the next few years, we're going to be adding on subscription services, rolling out e-commerce ventures, and telemedicine. All of these we feel should be well suited for fragile and conflict settings. This is kind of a quick snapshot of our social enterprise models and where they are around the world. In Myanmar, we actually hope to spin off our PSI Myanmar Social Enterprise Business Unit into a fully deconsolidated commercial entity by the end of 2021. Work is underway, and COVID be damned. So I want to spend a little bit of time on this map of Myanmar. It basically depicts the scale of our social enterprise work here. We have over 30,000 sales outlets in nearly every township in Myanmar. So we essentially cover the entire country. Of course, these outlets range from fancy 24-hour convenience stores, informal drug outlets that just kind of have they roll up their cart on a Saturday market day, or the little trolleys outside a bus station. Most of you know Myanmar has suffered from decades of prolonged internal conflicts involving a number of non-state armed groups in almost all the border states. And it's a chronic problem, and you know, we still try not to get used to it. But PSI's line ministry here, the Ministry of Health and Sports, has allowed our social enterprise work and therefore access to affordable health products in all of these conflict zones. So all townships are depicted and ratified in our memorandum of understanding with the ministry. We continue to provide the ministry with sales data, and the ministry gets involved with our product pricing to make sure that access is not prevented by exorbitant pricing. And the ministry often publicly mentions PSI by name as being their go-to partner for any private sector activity. So we're quite proud of that. The COVID-19 pandemic has effectively rendered the entire globe fragile. So I wanted to conclude my portion of the presentation with some top lines that cover this unique year. Sorry. So mercifully here in Myanmar, we have ample product stock and at last count, enough to last through 2021. However, our transportation, the market retailers, and the consumer have all been negatively impacted. And you can see on this slide that one recent study unsurprisingly showed an increase in interest in health and savings among consumers around the world. Globally, as well as here in Myanmar, we are starting to adapt to the new modalities of doing business. And currently in Yangon, we are observing a lockdown. And I think we're entering our third month of the lockdown. Because of our relationship with the Ministry of Health and Sports here, we do have some mobility. A lot of our field offices remain open, and we are allowed to work in our headquarters. So we can still keep priming the market and work in our other activities as well. And my colleague, Dr. Momo, will also spend some time talking about that with you all. So in Myanmar and elsewhere, we are already offering consumers tailored information on the pandemic as it affects us locally, and how to access our products. Our hotlines have replaced physical outreach, of course, because of the pandemic. And since we've all been locked down in our homes for 2 months, we've actually begun to mimic the restaurants with their mobile delivery. And we have been able to deliver direct to the doors of our consumer using 3 or 4 social media platforms and websites. And the business is starting to pick up. So, I mean, there you have it. You can order some orange scented FCAS condoms and have them delivered right to your door. Unfortunately, the oranges are sold separately. So that's just my overview. I'm definitely available for a deeper dive, if you like, on our global social enterprise work as well as Myanmar. But at this point, it gives me great pleasure to introduce a dear colleague of mine, Dr. Momo Nguyen. She's the National Director of our Sun Community Health Business Unit, and she's going to talk about the PSI Sun Clinic Network. And over to you, Momo.
Yes, thank you, Michael. And good morning, good evening, my seniors and colleagues from the different part of the world. Today, I am so honored to have this opportunity for sharing our Sun Quality Health Network operating in Myanmar since 2001, and is 20 years journey working in this country with the more than 50 ethnic armed group and 25% of population living under the poverty line, below the poverty line, etc. Next slide, please, Michael. This is the outline of my presentation. I will cover the what is Sun and its milestone and how we operate in the ground and our future as well. Next, please. In Myanmar, 54% of people living in urban areas seek care from the private providers, so that the role of private providers in the disease surveillance and service provision is very crucial and important. In addition to that, government of Myanmar aim and committed the primary healthcare oriented health system strengthening and achieving UAC in 2020. They are planning to engage with the private sector clinic in the long run to ensure that people are getting the basic EPHS without financial hardship. Next slide, please. The picture in the previous slide is our Sun Clinic, one of our Sun Clinic located at the peri-urban area of the Yangon city. Those clinics are privately owned clinic, and we are provided the operating the network with the fractional franchising model, where we provided the quality commodity and IC and provided training in order to help our Sun doctors in provision of the Juno hemp products to the client. And we, of course, we are facilitating in reporting of the Sun network data to the government in contributing the program, disease program. Next slide, please. The doctors who join us, because of the continuous learning opportunity, they can get the updated information and they can distribute the IC promo materials to their community. Most of them stated that because they could provide the something back to their community, their consumer, as a social responsibility. Next slide, please. So this is the milestone of Sun Network in within the 20 years period. We started Sun Network in 2001 with the reproductive health program, offer the family planning products like the OK pills and injectables. At that time, the maternal mortality rate is huge, and the country is challenges in assessing the quality healthcare products. It is now you will see that there are many services availability under our Sun Quality Health Clinic. They could provide now the maternal and child health, communicable, non-communicable disease with more than 15 health services and commodity in the ground. Next slide, please. I would like to briefly present how our work in the field in partnership with the Ministry of Health, and by getting the funding from the donor. Next slide, please. We PSI are getting the technical support and medicine supplies from the government in some program like TB and HIV, and we facilitate and train our doctors. We also created the demand creation activity by using the community volunteers, by using the existing pharmacy in the network, and we are developing the referral network to get the client drainage to the Sun Clinic. The Sun doctors, they could provide the health services to their client, and also, next please, they could refer to the diagnostic facility next tertiary care center if needed. This is the flow we are operating in ground. Next, please. And I would like to present our scale and scope of our Sun Quality Health Clinic in Myanmar. In Myanmar, we have around 4,000 GP clinic operating in the country of the 325 townships. Our Sun Quality Health Network exists in the 206 township of Myanmar and contributing 1/3 of the GP of our country. Next, please. This graph shows the numbers of the Sun Clinic in the different area of the Myanmar, offering the different health services, which is varies with the country disease burden, geographic prioritization, and etc. Among the 1,300 Sun clinics in our network, 1,200 can offer the variety of short-term contraceptive methods in their clinic. 900 contributed in the malaria diagnosis and treatment and involved in the malaria elimination agenda of the country. We also have the 800 clinic diagnosis and treating the sexually and reproductive health infection, which is very much important in the control of the HIV program. Half of the network providers are involved in the public-private partnership of the TB control program. Along with the TB, we also train the nearly 400 of the Sun Clinic in HIV testing and counseling. Starting in 2019, we start planning the bringing a healthcare solution to the SARA, so that we introduce the GMPSC self-injection in our basket of best-basing products, and around 300 clinics are equipped with the GMPSC at their clinic. And those of the clinic, we also have the long-term contraceptive methods that are IUT and implant. Nearly 300 clinics in the network are offering the non-communicable disease like hypertension, diabetes, and cervical cancer screening and prevention. And below 100 clinics are working in post-abortion care, dispensing of the ART medicine, and etc. In 2017, we could develop and tested the social strategic purchasing pilot project in 2 clinics in peri-urban area and 2 in rural setting. That would help us our learning in order to present to the government ready for the UHC roadmap. Next slide, please. That table show the number of the client who receive the services at our Sun Clinic, varies with the different service packages at the clinic. Next slide, please.
Let's check.
Average of 48 clients visited per client per month, which is affected by COVID. Next slide, please. Our Sun Clinic can contribute the National TB Control Program since 2004. Next slide, please. Next slide. In 2019, we could contribute 10% of the national case notification rate of the TB program. Next, please. The outlook, the look of the Sun varies in the 2020. First COVID case were found in one of the Sun Clinic in the rural area of the country, and he could probably manage and do the necessary contact tracing together with the public sector. The graph shows the Sun Clinic performance in 2020, which is mainly affected by the COVID with the nationwide travel restriction, and the Sun doctors has to make the necessary preparation of their clinic by fully preparation of the PPE and their arrangement of the waiting area with social distancing and install the hand washing facility in front of their clinic, etc. You will see that the service was decreased dramatically in April and May after we found the COVID, and slightly increased after the June, July, and August. It shows that Sun doctors are still contributing the national program, the disease program, in while the public facilities are busy with the COVID measure. Next slide, please. Pat?
Dr. Momo, we have to wrap up. Can you just please finish? Yeah.
Yes, so that compared with the 2019, in 2020, 1/3 of the client visit was reduced because the Sun doctors has to customize by using the teleconsultation and preparation of the PPE and contributing at our fever clinic to maintain and continue service provision at the ground level. The picture shows our Sun doctors provision of the implant insertion at their clinic. So PSI will continue engaging with our Sun doctors in the future direction of the country UAC by implementing the different program as necessary. Thank you.
Thank you very much to Michael and Dr. Momo for this very comprehensive presentation. I would like to highlight the fact that international NGOs and the humanitarian community are generally among the best documented interventions of private sector engagement in fragile and conflict-affected settings. It would now be interesting to give the floor to 3 other speakers who are going to provide first accounts on their experience in parallel or complementary realities that engage the private sector in these settings. I would like to give the floor to Harry Jean to talk about the continuity of care in dire circumstances. Harry, over to you.
Hello, everybody. This is a story about Afghanistan, an anecdote. It is not even anecdotal evidence. It is just an anecdote of what happened in Afghanistan when COVID-19 hit. I was in Afghanistan when it actually hit, and I got out on one of the last flights before all the airspaces closed down, but I have continued to remotely support the Ministry of Health and some of the private sector. And I hope to soon be able to go back to Afghanistan again. But when COVID-19 hit, it hit very hard. Afghanistan borders Iran. Iran had a very early epidemic, and but it also had a good million of Afghan refugees. And as good tradition in all epidemics in history, it was of course blamed on the foreigners. So there was an enormous influx of returnees into Afghanistan, 10,000 a day, and we now sit at around 700,000 that have returned from Iran, and they spread through the whole of Afghanistan and seeded the pandemic there. So the epidemic in Afghanistan really shot up very quickly. Afghanistan has a kind of hybrid system whereby most of the primary healthcare delivery is contracted out to NGOs. It was not designed for a war situation, but it actually comes in quite handy. Because in Afghanistan, the government controls the towns and the cities, but has no access to about 2/3 of their rural districts where most of the population lives. NGOs can operate there because they are considered kind of neutral, although it is not always easy in the middle of a conflict. And so that hybrid system works quite well. Since the fall of the Taliban in 2001, the BPHS system has now a good 4,000 health facilities with 80 to 90% of the population within 2 hours travel of a semi-public health facility. But the package that the BPHS system offers is rather small, and the quality is mediocre at best, with the result that 75, maybe even more of the total health expenditure is out of pocket. Probably about 93% of the medicine expenditure is out of pocket as well, and only 7% through the semi-public health system. Well, then COVID hit. And of course, like every country in the world, there was a tremendous shortage of PPEs, personal protective equipment, face masks and goggles, etc. And the international community kicked into action. The WHO and UNICEF did a splendid job. Private donors like Jack Ma from Alibaba helped, and many others. But then we came up against a problem, because in spite of the enormous role of the private sector, there was no distribution system in place. So the private sector couldn't get hold of any face masks. And well, the result was predictable: very high infection rates and quite a bit of mortality in health staff, especially in the private sector, because the PPEs were only distributed to the public sector. This led to labor unrest. It led to very harsh positions of the public sector versus the private sector. High stress levels undoubtedly contributed to all kinds of conflicts. And a lot of private health facilities just had to close their doors because half the staff was sitting at home, quarantined. They couldn't access testing, they couldn't access PPEs, and that was really not the ideal situation. The supply, the medicine supply, which I'm talking about now, in Afghanistan is not very well organized. There are basically two main supply channels. One is for the top end of the market. It comes mainly out of Dubai, and it concerns branded medicines. There are good hospitals in Kabul, there are good pharmacies. You can even order on the internet and your medicine is delivered by courier at home if you live in Kabul or another big city. But that is really for a small top end of the market. The middle end of the market includes the semi-public NGOs. There is no central medical store, and the Medicine Regulatory Authority is, well, slowly being established, but not really functional as yet. That sector buys mainly generic medicine from Pakistan, and it comes by road. Both sectors were, of course, interrupted because of the closure of the airspace and the borders, but it did not cause a real disastrous impact because the closure did not last extremely long. The lockdowns, of course, caused problems, etc. But problems were already there because of front lines, and the lockdown didn't make very much of a difference in that. But an important reason why there was not massive shortages was that the population started avoiding health facilities. This is again something that we see all over the world. People were avoiding care because they were afraid of COVID-19. And this was, of course, a mixed blessing. But it picked up. The private sector started to import PPEs and medicine again as soon as the market started delivering PPEs and the borders opened up a little bit. But the uptake did not immediately increase. People continued to avoid public facilities. And it was also caused because the epidemic was very severe. By July, 53% of the population of Kabul, in a properly randomized study, already had antibodies against COVID-19. So that shows you how severe the epidemic was.
2 more minutes,
But,
Harry.
yes, but an unusual thing, there was a third pharmaceutical supply chain. And this was something that we had been completely neglecting, and that was the gray supply chain. Drugs, lower quality drugs, were actually smuggled in from Pakistan through porous borders and went particularly through the opposition-controlled areas. And they were sold through medicine shops with very lowly qualified staff, sometimes only first aiders, sometimes as an adjunct to some veterinary medicine, tea and sugar. But that system seems to have doubled roughly in turnover. And now one wonders whether this is something we still should look at. The quality of drugs is poor, the quality of the human resources is poor, but is this something that in a war situation where the ministry has no access, is that something we need to look at again? 20 years or so ago, we looked at selling anti-malarials in grocery shops, in neighborhood shops in East Africa, but it has a bit dropped off the agenda. And I think it would be worthwhile to see whether this should be back on the agenda, because they may be offering a service of a very, very modest quality where no other service can be delivered. And that was the story, the anecdote of Afghanistan. And maybe we should try to find some more anecdotal evidence. Thank you.
Thank you very much, Harry. This was a very inspiring story also about the variety of private sector initiatives that one can find in dire situation. I would like to invite Dr. Botaina Attal to tell us her anecdotal story about informal networks in Yemen. Botaina, over to you.
Thank you, and Assalamu alaikum. Greetings to everyone. Well, actually, what I'm going to talk today about is based on a very early findings from an EMERALD study on the potential role of the private health sector in COVID response. And I would like to thank Dr. Hassan Salah for giving the permission to share the findings. I can't find or see commonalities between Yemen and Afghanistan. Yemen has been into a long-term conflict and war that left the country with a very bad humanitarian crisis. It's a country of 30 million people. We are now facing widespread food insecurity and poverty. We have social and health needs that are greatly unmet, and a big proportion, 80% of the population are poor. The infrastructure has been damaged because of the conflict, and many of the health facilities are not functional at the moment. So the health system is also badly hit because of the conflict. And the health system is made of the public sector, which is being starved of the financing. It's being debilitated of its human resources, who haven't received salaries for over 4 years in some time. And because of the political divisions, the country has come under different authorities that affected the health system in the different parts of the country in different ways. And that reflected also on the COVID response. So beside the public sector, we have the private sector, which Nigel has mentioned earlier, and it is a growing sector, widely unregulated, with little information on the quality and cost of the services. It is very heterogeneous. We have clinics, polyclinics, hospitals, but a few provide very specialized services or of quality services. So when the COVID was first discovered in Yemen, it came to this like a devastated country and a devastated health system. We had by April, when the first case was confirmed, we had preparedness and response plan in place with some funding which was inadequate, of course, similar to all the humanitarian funding for Yemen during the last couple of years. So the response, unfortunately, at the beginning was kind of disorganized, as the key informants in this study told us. It was a panic, a status of panic, status of paralysis in some parts of the country. The management of the ministries of health was new, and roles and responsibilities were not clearly laid out. So that left a huge gap in the provision of care for the people with COVID. The government or authorities have tried to apply social distancing, lockdown, and other containment measures, but of course this was very short-lived, and people could not follow that because they had either to die of corona or die of starvation. The public health facilities did not have sufficient supplies, PPE, similar to Afghanistan. We did not have enough medicines, and the health workers were reluctant actually to work. During that time, that's about the public health sector. During that time, at the beginning, the very early years, the very early days of the response of the panic, paralysis, some of the private health sectors actually took initiatives, and some of the doctors individually took initiatives to provide free of charge care. And some of the hospitals provided subsidized care for people who had symptoms of corona. On the other hand, severe cases were not able to access the care because it was very costly to the hospitals. So on the one hand, the public hospitals were overwhelmed, and the private hospitals asked for payment, a big payment ahead to accept receiving and admitting the patients. Another picture comes from Hadramaut, right in the eastern part of Yemen, where some informal partnerships were formed between the Ministry of Health, the health office there, and few private hospitals, where the private hospitals provided subsidized and free of charge testing for COVID and treatment, and they were reimbursed later on by the health sector, by the health offices. Mind you, that was because the health offices had some kind of support from businessmen in that area, so that allowed them to develop these informal partnerships. In Sana'a, in the northwest, the private health sector was not really involved in the response, or formally involved in the response to COVID. Some of them and some of the laboratories were banned from doing tests or providing care or admitting the cases of COVID. One hospital, private hospital, interestingly, managed to have a partnership with a business company in the country, and this is a very famous company who had all his employees and families insured So this hospital, the private hospital, had the agreement with a business company to cater for all the cases that needed isolation or treatment in the hospital. And the whole facility was turned to COVID isolation and treatment center. The
2 more minutes.
The hospital received the PPEs from the company. They were promised also ventilators. So all in all, there were mosaic interaction between the public and private, and there were also a heterogeneous response from the private sector. Another form of the private sector involvement is the informal networks. And 2 major examples come here. One is from a businessman group who set a fund and coordinated with UN OCHA Health Cluster in determining the needs of the isolation centers and procuring and distributing these supplies and equipment. Another example are the health professionals, Yemeni health professionals who live outside Yemen. And these professionals joined and raised funds as well. This group sourced out PPEs through their informal channel in Europe, Canada, and provided these PPEs and equipment to hard to reach areas in Yemen. They worked with NGOs, they worked with some of the health offices. The Yemeni professionals outside used also social media to deliver lectures and for teleconferencing, for knowledge exchange on the epidemiological situation and the updates of the treatment of the coronavirus. So just to wrap up, the private sector role was mainly in service provision. It was inconsistent across the regions of the country. That's probably because the private health sector was in itself heterogeneous on the one hand, but also because the public health authorities had different views of the private sector involvement in Corona. We found different initiatives from the private health sector in setting up public-private informal partnerships, small ones, although we don't have assessments of the success of these partnerships, but these are examples that fill in gaps of the health services. So to conclude, the relationship was ranging from like a warm shoulder, cold arm, and sometimes sharp elbow between the public and the private sector. The informal groups are really important and vital in supporting the people inside the country. Thank you so much.
Thanks to you, Botaina. I think we are hearing very clearly that there is a number of dynamics that are happening unnoticed in a number of these settings. And it's important to maybe go back to Harry's questions about the need to bring anecdotal evidence to the agenda so that it can be documented. I would like to ask now the question to Professor Dalmar to give us an account of what can happen once the private sector tries to self-regulate. Professor Dalmar, over to you.
Thank you, Barbara, and good morning, afternoon to everyone. This is Dr. Dalmar talking to you from Mogadishu and Somalia. And just briefly, you know that Somalia has suffered from chronic insecurity and protracted civil war for almost 30 years now, although the situation is now controlled and there is no ongoing fighting in the country, but there are sporadic explosions that can happen in big cities like Mogadishu. But the picture, especially in the healthcare in Somalia, is that over 90% of it is provided by the non-state actors, mostly private for profit, but also increasingly private for non-profit and NGOs supported by the donors. But the private sector that controls most of this healthcare, especially the secondary and the tertiary one, was not really regulated, and the government lacks any legal framework or authority to control or supervise them, as the government authority is confined in big cities when most population is living in remote areas and rural areas. So with this, what happened is that there was a growth of a private sector in all aspects of social services in Somalia, including the health. So water, electricity, education from primary to university is provided by the private sector. And that, as you can understand, with no government regulation, provides for quality problems and bogus or sometimes non-skilled workers providing healthcare. So in light of that, myself, I'm a medical doctor and I was involved in private sector. So in 2014, we started this dialogue among big private sector providers. If we can self-regulate ourselves with two main objectives. One was to have a branding so that we can tell the community that any clinic with AFINET, we call it AFINET, AFI in Somali or Arabic means health and net means network. So we came up with AFINET. We actually got enrollment from 200 self-regulating health facilities that are independently run to become AFINET members. And it has two main objectives. One was to provide affordable and quality assured healthcare to the most vulnerable Somalis. And secondly, to train these health facilities to provide customer care, business skills, because most these healthcare facilities were owned by medical doctors who may have come out from medical school but lacked any business skills. So AFINET, if you became a member of it, was providing you business skills, cash flow management, planning and budgeting, but also customer care and marketing strategies. And with that, we also engaged in the government, which is now becoming more stronger to actually start dialogue between the private sector and the government so that we can have this public-private partnership, especially in some areas like emergency. But we had difficulty. AFINET was started in 2016. The government was not really keen to work with us. Most of its interest and attention was to actually talk to the donors. For these staff, civil servants of the government were more interested in flying out to neighboring countries and getting daily subsistence allowances and maybe some funding for regulations rather than work with the private sector. So that was the state that we were working until COVID-19 struck Somalia in March 2020 with the first case of imported Somali who flew back from Europe. And the government lacked any laboratory facility. So the first week or so, they were collecting samples of suspected cases and flying them out to Nairobi in the neighboring Kenya, and they are called KEMRI to do that. But as this was sensitive issue of declaring COVID-19 positive cases, and they looked at it as a national interest subject, one member of AFINET laboratory actually approached them. It had the staff and capability, and it provided its laboratory for the government to use without any charge. So the government actually in April started using that laboratory, AFINET laboratory, to test and declare cases on daily basis. And so that was the first actually opportunity for us to engage with the government. But during this COVID-19 pandemic, the private sector was the main driver of health promotion, social awareness of COVID-19, providing training and facilities, but also when the government got donations from donors and outside people, and they established the first isolation unit in a hospital in Mogadishu, they lacked human resource. So again, the private sector came to the rescue by providing trained doctors and nurses in ICU. So that actually strengthened also our relationship and partnership with the government. The private sector also in Somalia is engaged in setting policies, social distancing, and other COVID-19 related policies with the government. We are also engaged in evidence and research related to COVID-19. So at the moment we are running different research. As you know, there is this empirical issue that Africa has not been affected by COVID-19, whether it is due to lack of reporting or not. So we are engaged in different research that will come out later this year or early next year on excess mortality due to COVID-19, on morbidity, on syndromic prevalence of COVID-19, and in big cities like Mogadishu, in seroprevalence of antibodies against COVID-19. So in conclusion, I can say that in Somalia still there is widespread irregulation and disrupted private sector that is providing healthcare. But with the advent of AFINet and this now opportunity to work with the government, we hope in the future that we will have public-private partnership that is actually working together, because that's the only way Somalia can achieve universal healthcare coverage very soon. Thank you so much for allowing me this opportunity. It's back to you, Barbara.
Thank you very much, Professor Dharma. We are hearing two things quite clearly. The moment the private sector got self-organized, there was an opportunity to become a better partner and a better interlocutor for the government. We are also hearing quite clearly out of all of this presentation with which we would like to close the second part of the webinar, that we cannot afford not to engage with the private sector in fragile and conflict-affected settings. We are slightly running out of time, so I would like to first acknowledge the fact that a number of your questions have been answered in writing by the concerned speakers. I would also like to encourage those of you who still have questions to address to the different speakers to reach out to them. The information will be shared after the webinar. I would like to maybe take up one question that didn't get an answer, to address it to Nigel. Is there any information on clients' perspectives, on client satisfactions, on service providers, both private and public, or any data on client satisfactions that emerges from your study? Over to you, Nigel.
Thanks very much, Barbara. I was about to type this out, so that'll save me typing in response to Berger's question. Yes, we did, in each of the countries, they did a questionnaire. It was really informative. It's not quantitative, but qualitative comments. On the whole, I'm looking at from about, I think all 9 countries actually, 8 of them, not in Syria. On the whole, good reputation, much better equipped, high professionalism, for the staff point of view, better pay, more opportunity, good, cordial treatment, friendly. Afghanistan, some of the things Harry was saying, there was a comment about, some of these small scale ones working pro bono for poor patients in really little areas, which is surprising, and that's different. That's interesting. And they provide more competition. On the negative side, always high cost, too many diagnostics and procedures not needed, expensive interventions not needed, targeting wealthy people, discriminating against poor patients, and staff missing out on public health training opportunities. Very quick summary. Thank you.
Thank you. I think we will just have to skip a question and answer broad session. I would really prefer that we try to organize a follow-up for having a proper debate. And again, I would encourage participants that remained without their questions unanswered to reach out to the speakers. Let's open now the third and last part of this webinar, asking David Clark to please explain to us how what we have heard so far in practice links up with the policy work that WHO is conducting. Over to you, David.
Thanks, Barbara. Can everybody see my screen?
Yes.
Thank you. So just very quickly, I wanted to just briefly, before I get into my comments, And I found the presentations all really excellent, and I really thank the speakers for making time for us today. We've been working at WHO HQ for 2 years now on a new strategy for private sector engagement, because we recognize the importance of this topic. And it's important to all countries, whether they be rich countries or fragile states. So we think that it's critical that we support our member states, all of them, to have a well-governed health system where public and private actors can collectively deliver on the realization of UHC. And so that particularly means working with the private sector. So this work has culminated in, oops, all right, just going to go. Sorry about that. This work has culminated in the development of a new strategy on private sector engagement that has been developed by an expert group that WHO convened, and we're about to publish the strategy. And this is the conceptual framework that we are using for our work. And you might think it's a bit strange to be talking about a strategic approach when we're in the middle of the COVID situation and an emergency. But what we've found is that the lessons that we've learned from the strategy, which really are around the fact that many countries have weak governance capacity to deal with the private sector, are really important for the COVID situation and really important for fragile states. So these are the key governance behaviours that we've developed with our expert group over a 2-year period. And we think, and we're going to be doing some work over the next year to elaborate on what these are, what they mean, and how they can be implemented in different country settings. I also just wanted to briefly touch on COVID, as we all have to at the moment. We've been doing work on COVID and private sector engagement for about 8 months now. At the start of the epidemic, we realised that, as many of the speakers have said, that the private sector is a really key interlocutor in providing services in the pandemic, particularly in fragile states where we have weak public sectors. So we started off with a call to action very early on in the piece to stress the need to work more with the private sector. We did quite a lot of work over the last 8 months in relation to COVID, looking at the private sector's involvement and the struggles that many countries were having to have the private sector involved in the COVID response. And that's culminated in a variety of tools that we've published. These are all on the Health Systems Governance Collaborative website. But one of the key lessons that we've learned from all of this work is that while COVID has presented many challenges and really highlighted the problems with weak governance for mixed health systems in many countries, it's also generated a lot of opportunities. There's been a lot of discussion in the media and in academic community about the need for a new way of doing things post-COVID. And we think that the lessons that we can learn from the COVID situation, and also I want to critically say the lessons that we can learn from the various case studies that have been presented today are super important for us to actually generate something different post-COVID and to define what we're describing as a new social contract between the public and the private sectors. I just wanted to, I don't want to go on too long about the strategy, because that's not what this is about, but we have these 4 elements of the strategy that we are trying to use as the basis for implementing it. And I want to zoom in on the 4th one, which is support learning and technical guidance. And this is really what we've been talking about today on the seminar. For me, it's amazingly important that we capture in a more detailed and systematic way the lessons that we've learned on this seminar, particularly the anecdotal scenarios that we've had from the various speakers. To me, these are really important areas that need to be elaborated on and studied in more detail, not just in relation to the countries in question, but also so we can get some cross-country and cross-regional learnings that can be applied and used by other countries. So as part of our work in implementing the strategy, we're really keen to work with the research community to come up with a new research agenda to help us to deliver this new social contract between the public and private sector. We think there's a lot of really good research out there in relation to describing the problem, but we're not so sure that there's enough research on describing the solutions and analysing which ones work and which ones don't. So we are really keen at WHO to talk to the research community about a new research agenda on this topic, and particularly keen to hear from people like the people who gave the anecdotal case studies today, to better understand how we can better research and describe and evaluate how the situations that have been described in these anecdotal materials, put some decent resources around them so they can properly be studied and published and then used by other countries. I'll stop there, but I really wanted to thank all of the presenters for the really interesting presentations, and I'm very sorry we didn't have enough time to talk through in more detail and discuss the projects that were being presented, but I think they really all illustrate the importance of this research agenda for strengthening work on private sector engagement in the longer term. Thank you.
Thank you very much, David. Thank you also for keeping the time, which I'm really, really conscious about. I think your presentation serves a bit of a wrap up of the main message that's coming across today's webinar, which has a lot to do with getting access to more documentation, to getting access to information that flies unnoticed somewhere underneath the surface. And we need to find ways to get it up and documented in a proper way. And most probably platforms like this one, like the mutual learning platform, are a start that allows all of us to create a proper community around research on private sector engagement in all different types of settings. So I would like to take this opportunity to maybe encourage all of us to repeat this kind of experiences like today and try to organize follow-ups so that we can have time and space for discussing in more details not only the challenges, but also the type of intervention that are promising and that are working on the ground. I will close here and give the floor to Priya for final remarks. Thank you very much to all our speakers and the participants for staying with us today. Over to you, Priya.
Thank you so much, Barbara. And I'd like to really thank our speakers today evening. Thank you, Nigel. Thank you, Michael, Michael Shomi, Dr. Harry Green, Dr. Bathania Atal, Dr. Abdi Dalmar, and Dr. David Clark. Thank you all again. I think a couple of things have really echoed through this presentation today. Questions around quality, questions around documentation, questions around the emerging role of the private sector. The one thing that I missed, I think, a little bit was the role of and agility of the digital technologies that are beginning to leapfrog a lot of the capacity gaps across many countries. There were questions around the grayness of supply chains, the need for informal networks, and how they have actually interceded where health systems capacity has been weak. There have been, there were discussions around private hospitals and payments, and then finally around while there were indeed many challenges that COVID has brought about, there have also been many opportunities for better understanding mechanisms of engagement and social contracts between public and private sectors. We're really hoping that this mutual learning series and the subsequent mutual learning platform for mixed health systems offers an opportunity for researchers like yourselves to join us in better exploring mixed health systems, in better documenting some of the absolutely amazing anecdotal evidence that is coming through from countries like Yemen, from Afghanistan, Myanmar, and many other countries. I think this is a great opportunity to bring together diverse stakeholders who make up mixed health systems and to see how we could all work together to be able to achieve a fundamental goal of better access, quality, and eventually universal health coverage. Catch us in November 19th, where we would like to present to you another aspect of public-private partnership. This is in primary healthcare models during and beyond COVID-19. We will showcase the government of Singapore. We will have the government of South Africa, and from the United States, a PPP with the province of New Jersey. So please catch us then, and we'd be delighted to share more information with you very shortly. So once again, thank you very, very much. And we look forward to keeping in touch with all of you through this webinar series going out into the new year.